The content discussed in this episode may be specific to the guest's organisation or location and may not be applicable to other organisations, states, territories or countries. The material presented in this podcast is for general information purposes only and should not be considered health, legal or financial advice. Medical administration is a rewarding profession, but it comes with challenges. So what is it like, and what should you do if confronted with a monumental administrative difficulty? This is the podcast that takes unfortunate scenarios and explores the essentials of clinical governance to find solutions. I'm Dr David Rankin, a very experienced medical administrator and lead fellow with the Royal Australasian College of Medical Administrators. And this is Safeguarding Healthcare, the essentials of clinical governance. Today, artificial intelligence goes wrong.
I think our younger graduates are going to be facing this exact issue.
That's Professor Erwin Loh, President-elect of RACMA and Chief Medical Officer at Goulburn Valley Health. As well as having academic appointments at Melbourne, Monash and Macquarie universities, he is also a barrister and solicitor. But of particular interest to this episode, Professor Loh is also a member of the Association of Professional Futurists, with an interest in medical futurology and AI. So I'm challenging him with a difficult scenario.
Generative AI comes up with answers that do not make sense, basically. They make it up.
In today's scenario, we visit a hospital emergency department that has recently commenced creating patient discharge summaries using an artificial intelligence computer program. This process saves significant doctor time, as the program generates the summary by reviewing the doctor's clinical notes and then creating an easy-to-read, plain language document. It can generate the report in a range of languages. Unfortunately, a recent discharge summary contained a recommendation that the patient take a herbal remedy that is not available locally, and for which there is very little evidence for its effectiveness. Nobody has any idea where this suggestion has come from. I started by asking Professor Loh what the key issues are that this scenario raises.
I think the scenario that you've just shared, although it's hypothetical, will over time, I think, become quite real for a lot of our clinicians who are going to be practicing into the future. I think our younger graduates are going to be facing this exact issue, and I think it's something that we need to think about. So when it comes to the scenario that you've just shared, presumably if the ED is using AI to generate discharge summaries, and we know now that this is actually eminently possible in the US, there are companies that are selling products that actually do this. And in your scenario, it looks as though the discharge summary has included a recommendation around a herbal remedy that is not available locally and it's not effective according to the evidence. Now, that is interesting. So how AI works when it generates discharge summaries, that it takes information from the clinical notes. And usually the systems that are being used now to do this, which is quite different to maybe even 2 years ago, is they're using large language models or generative AI to do these discharge summaries. And so there are two possibilities here, right? The large language model has somehow picked up that this person has an interest in herbal remedies or uses herbal remedies and has just pulled it in somehow. Or more likely, actually, is that occasionally generative AI comes up with answers that do not make sense, basically. They make it up. And there have been a few high-profile cases in the media that this has actually eventuated. So it's possible that this could have happened in this case. So your question being, what are the key issues? Clearly, one of the key issues is the unreliability of the health information that's being generated by the AI in the discharge summary, and whether it's significant enough to cause patient harm that a medical error could have risen out of this. So it becomes, and this is a podcast around clinical governance, it becomes a clinical governance issue.
There's a huge difference between the information that, say, the Mayo Clinic put up on their website, which is reviewed by multiple very senior doctors before it's published, and I guess what's available on the web or using something like generative AI. How can we make sure that the information that AI generates is trustworthy?
Well, the short answer is currently there is no guarantee that information that AI is generating, in particular large language models that are being trained on data sets that are being publicly made available on the internet, there is no guarantee, is the bottom line. So at the moment, there'll be no company that will be promoting the fact that generative AI should be used as a frontline clinical decision-making tool. It must always be supplementary to an actual human doctor making the final decisions. So at the moment, you're completely correct. There's a lot of work to create large language models that are restricted to health information only. So, Google's MedPalm, and there are specific LLMs that are, dedicated to medical information only. But there is still an inherent risk. The bottom line with this new generation of deep learning models of AI is that there is still this black box issue, because we are developing artificial intelligence to learn like human beings from experiencing a lot of data. When they make a decision, because we can't read their minds and because we're not dealing with simple algorithms that follow hierarchical process maps that are linear, sometimes if the decision surprises us, we can't work backwards to figure out, hang on, logically, how did they make that decision? And that has happened again and again. And so a lot of researchers are trying to figure out a way to basically open up that black box to understand, in the end, why and how AI is justifying the final decision.
Dr. Watson was probably one of the most spectacular examples of an attempt to use computers to collate peer-reviewed evidence, and yet after billions of dollars investment, it failed. Why is AI different?
So Dr. Watson is AI. It's one of the earlier versions of it, right? I mean, when it came out and IBM kind of promoted it, it was put forward and there were studies to support it, right? So they actually did trials to show that, Watson was able to look up thousands and thousands of different chemotherapy protocols in oncology in seconds compared to if you had a human do it. There was a study that showed that a human would have taken years. And, Watson took seconds. And so it was being sold to oncology hospitals. There were some well-known American cancer centers that took it up, and they were trying to sell it over in Australia too. Now, it spectacularly failed because in the end, basically the idea was you put in the patient and it will tell you, based on best evidence from around the world and all the evidence, this is the protocol you should use. The problem is it didn't do it. It didn't recommend the right protocols. Oncologists, as it happens, knew what the latest protocols were. They didn't need Watson, so it failed from that point of view. Now, generative AI is meant to be better than Watson because it's a next level up, right? It uses more intuitive thinking. The idea is that it formulates all the information into a preferred treatment plan, just like a human being would. And that would be the trick, is whether that's right. Because part of the issue, part of what humans do well is we have the ability to focus on the right information and get rid of the crap, right? But AI just absorbs everything. And so, if there is enough misinformation or biased information, that biases the whole kind of attitude of the AI. So I think that is the challenge. There's a lot of work happening, though, to kind of fix that.
That's an area that I'd quite like to explore because AI picks up information predominantly that's available on the web and passes it. But the people that generate information on the web tend to be white, young, Americans. And so if you're a non-English speaking person with a rare disease or from another country, the information that generative AI can use to inform its knowledge base may not apply to you.
So, David, you're describing not just the problem now, but the problem that has always been in existence when it comes to medical evidence. Clinical trials in general are biased towards middle-aged white people in Western countries. And that's where most trials are. Now, that's just changing because of the fact that it's now cheaper to do trials in some of the other countries around the world. But having said that, there is still a bias against women, against minorities, against older people. So that's one thing. The bias has always existed. Now, the internet brings similar biases, but probably broader biases, because now you are being exposed to the lowest common denominator of humanity. And there's been a lot of studies that have shown that if you let a deep learning AI loose into the internet, especially if they get access to the worst parts of the internet, what happens is those models turn out to become racist and sexist. There was a nice MIT experiment that found that their AI became psychopathic just from learning from the internet. And you can actually interact with that AI on the MIT website. So that's the danger of free, it's like having a child, right? Some of us have kids, and you don't want to have your kids free access to the internet, especially when they're growing up and they're learning. So you want to teach them the tools. So it's about teaching AI the tools to know what is good quality information and what is misinformation. And worse, what is disinformation, where it's purposefully designed to mislead.
So one of the other biases that's often talked about is sycophancy, where AI learns, and so somebody has to say, yes, that's right, you've done a good job, I like this, and that biases the way the AI responds next time. However, that sycophancy ends up with AI more likely to say what you want to hear rather than what the truth is. How do we guard against this bias of sycophancy?
It's a very good question, David. So, first of all, the point I'll make is that all of us, even as humans, grow up with biases because of the way we are taught, the way we learn. Just as you say, a human being has biases, and when they teach an AI, they transmit the bias. That already happens in our educational system. We grow up in our own particular family units where our parents have biases, and we grow up learning those. We learn in our own educational systems, and for most of us, it's in a Western culture that has its own frame and perspective. Some of us have religions and faiths that gives us moral values that, points us towards a particular direction. So I think, first of all, as we know, when we teach bias, this is, as a principle, the key is to acknowledge that they exist, to overt those biases, to actually say, these are the biases that we have at the moment, and then create a system where the AI compensates for that. So, for example, if we know that the internet has a bias towards Caucasian people, there's a neat paper recently around dermatology AI systems and the bias against people with darker skin, right? So if you know that, then you can proactively compensate for that. You can mitigate that. But the point is you got to understand there is that bias in the first place. So it's about understanding the potential biases and working it into the learning system with the AI so that they can compensate for that. But you can't avoid biases.
Thanks, Erwin. In a couple of your articles, you distinguish between non-clinical AI, used in finance, coding, food services, and clinical AI, which supports health professionals in their decision-making. Can you expand about the difference and, I guess, the dangers that might be inherent in clinical versus non-clinical AI?
Sure. So in health, AI is being implemented and currently used in multiple ways. I think already, because AI is built into a lot of the IT systems that we use from our vendors in our health system, it's being used to generate insight around analytics, around our finance systems, as you say, HR systems, to pick up fraud. And so those are not specifically frontline clinical systems, although clearly if those systems fail, they would have an impact on the clinical workforce and therefore a flow-on impact onto our patients. So those are and then you've got those AIs, robotic process automation, RPAs, that help to automate things. So already we know nurses are using RPA to roster their colleagues because it's much easier than using Excel spreadsheets because the AI just works out the best placement. So again, not frontline clinical systems, but if they fail or they have an issue, there might be an impact. The key here is, and this is the struggle that the FDA in the US and TGA in Australia are considering around, what do we regulate? And they have decided that they will regulate software just like a medical device if the software makes decisions that are clinical. Basically, they make clinical decisions where clinicians on the front line rely on them that have an impact on patient. So, at the moment, the whole framework that we use for devices, they're going to try to adapt to software that has a medical device if they are clinical software. So that distinction is important because there is clearly a gray area. But, they've already said in the examples, the TGA has used sepsis monitoring algorithms as an example. They will be regulated because they tell clinicians this person probably has sepsis, do something, and clinicians act on that. And because there's direct clinical impact on patients, they have to be regulated to ensure, just like a device, and there's research to show that they're reliable and safe and effective. And then there are guardrails around their implementation. I suppose the issue for a lot of health services right now is that clinicians are being sold by vendors all these different systems, and clinicians are actually implementing them right now in our hospitals with very little governance, to be honest. They don't even go through our new technology and clinical practice committees, where I think they should. And I know now state governments, definitely in Victoria, they're now pushing for that to happen. They are now telling hospitals to review their processes to ensure that new software that has clinical importance get reviewed through a governance process, and likely has a new technology in clinical practice, but maybe as a AI subcommittee of that governance committee.
Which raises the really interesting point. If a doctor keeps making bad decisions, we can report them to APRA, we can review their credentials, we can sue them. Can you sue a software package?
Well, you can't. Well, right now, AI has no legal entity status, right? They're not suable at all. AI is essentially a whole bunch of coding, and they have no agency and no accountability or responsibility. So the best you can do right now, and that's what lawyers would do, is to sue the legal entities that surround the AI. So potentially the vendor, the company that released the AI, the programmer that programmed the AI, the hospital clearly that has bought the AI, the treating team, so the doctor who relied on an AI to make a clinical decision. Now, clearly at the moment, that person, the clinician who has made the clinical decision based on the AI's recommendation, is the primary person holding the liability. Because right now, one would argue that the clinician is still making the final decision. But, it'll be the clinician, the nurse, people, the treating team around the patient. It is an interesting question, though, David, because there will come a time when AI will be making the decision without any human input. And when that happens, who is liable, right? That's when things get a bit tricky, and the law hasn't caught up with this. The law, doesn't actually have a solution to it. In the EU, they were very close to deciding to give AI legal status as a legal entity that can be sued, but it'll be like a company. You know how companies have directors, right? So you can sue a company, but you have to have a board of directors. So there will still be humans sitting on top of that legal entity, but you can still sue the AI. That never passed, but they were close to. And I think they're revisiting that. And I suspect at some point it will happen, especially when AI gets to the point that it does become independent, right? The whole goal of AI at the moment is to move from specific AI, to general AI, from artificial narrow intelligence, which is what we've got, to artificial general intelligence. And then the ultimate goal of AI research is artificial superintelligence, when the AI is smarter than everybody combined. I'm not sure whether we'll get there, but that's the aim.
It raises an interesting question. In one of your papers, you noticed that a computer scored 86% in the US medical licensing examination. That is a score slightly higher than mine when I did mine a number of years ago. Should we expect the computer to be 100% accurate when we know any good, experienced clinician is probably no better than 85% accurate in their decision-making?
So you raise a very good point here, David. This is a debate that the AI community has been having around the public's expectations of AI. This is very relevant when it comes to self-driving cars, right? There's a lot of parallel between self-driving cars and the development and AI in health. And I'll explain. So right now, human beings die in the thousands in car accidents. In Australia, the road toll is high, right? So we know that human beings are just dangerous on the road. We believe that if everybody is in a self-driving car, it will be safer for everybody. As in self-driving cars, will just follow the rules. They can detect each other. They will avoid each other. They will just kind of, if we can get to that utopia, the road toll should fall dramatically. In fact, we're very close to zero because everyone's in, AI-controlled cars. The problem is, every time one of those self-driving cars has an accident, and we hear about them in the media, it gets dramatized. It's big news. Someone's died in a self-driving Tesla. But if you look at those deaths, they are still fewer than the deaths that are in human-controlled cars. And this is it. So there are articles about this, right? The public expects AI, just as you said, to be 100% safe. And nothing's going to be that. The point is, as long as AI is better than humans, as long as AI is safer than humans, then the argument is we should use AI even if AI has an error rate. And it will have that because AI is never going to be perfect. And so I think with health AI, that is the challenge for human beings, right? There will be mistakes. And I think as a profession, as health practitioners, we need to understand that if AI does make a mistake, it's not the end of the world. It's likely still to be safer than humans, maybe. I mean, we are not at that point of the debate, but the debate will happen when surgical robots start to cut out the wrong thing, right? Or cut out the wrong limb. Do we go, oh my gosh, we've got to stop using surgical robots forever? Well, I don't know, right? So, do you know what I mean? Like, if it's still less frequent in humans, it's probably still safer. But that's the philosophical debate that we will need to have around AI.
Our tolerance for error on AI is quite different.
Well, that's right. We expect them to be much higher.
So where do you see AI going over the next, say, 2 years in healthcare? There's an enormous amount of discussion about it at the moment. Where are we headed?
You know what? On the one hand, I can say likely that there will be incremental growth. You're going to start seeing more and more EMRs, more and more products in health incorporate AI in a very transparent way. You wouldn't even know it, just like our iPhones and mobile phones have AI and we don't think about it. That's likely going to happen. Dictation systems are going to be better because of AI. All of that's going to happen, right? And we're going to start drafting reports, discharge summaries, medical notes. The recent Lancet study around that showed that AI medical notes were more accurate than doctors' notes. Interesting. So we're going to see that, and it's going to help us be a bit more effective. So that's one answer. The other answer I'll give you is that I don't really know, because remember, about a year ago, or just over a year ago, generative AI didn't exist, and it just came on. And all of a sudden, like, what the heck, right? I mean, when I was writing about and learning about AI, LLMs weren't even, people knew about them, but they weren't in production. It just kind of switched on, and now people are using it. I suspect something like that's going to happen in the next couple of years, right? Something new is going to happen. And it's just going to shock everyone. And then it's just going to be adopted without even much governance. Like, people are just going to start using it. So I think AI is exponential at the moment. I mean, the research is exponential. There are risks with that. A lot of governments are worried about that. The fact that there is very little guardrails. I mean, a lot of the AI researchers are warning about the fact that, what if we can't control AI? What if it gets to the point where it starts making its own decisions? And the point of the matter is this, right? And I'll just make the point. Right now, human beings, you and me, our brains go at the speed of electrons, right? We can think reasonably well. We're self-aware, but we are limited. We're limited by our brain power, by the fact that we can't multitask properly. We're slow in our thinking. We've got short lifespans. And we have hormones in our body that distracts us, right? AI has none of those limitations, okay? We are creating quantum computers that are going to work in a quantum state. We're creating photonic chips that go at the speed of light. And we've already got this deployed, right? Quantum computers and photonic chips. And they're combining those two. And then they're going to add AI on top of that. So in the future, computers are going to think at the speed of light in the quantum state and have thoughts that are just beyond ours, right? They're just going to be, whether you want to call that intelligence or whatever, who knows? But they're going to think faster than us. And at some point, they're just going to think better than us, right? So what does that mean for us as a species, right? As life? Is that new life, right? So I think those questions are going to be interesting for humanity. Now, some people are going to go, well, that's science fiction. But you know what? Science fiction is already here. So I think we'll just see what happens.
Thank you, Erwin. There are so many more questions that we could explore on artificial intelligence. Perhaps we should get back together in a year's time and see where we've got to. But I'd like to thank you so much for your contribution to the podcast today.
David, it's a pleasure to be here. I'm glad we can talk about this, and I'll love to come back.
That was Professor Erwin Loh, President-elect of RACMA and Chief Medical Officer at Goulburn Valley Health. And that brings us to the end of this episode of Safeguarding Healthcare. I'm Dr David Rankin. Follow Safeguarding Healthcare free on Apple Podcasts, Google Podcasts, Spotify, or wherever you listen to podcasts. This podcast is produced by Sound Cartel for the Royal Australasian College of Medical Administrators.